Let's see. Can everybody see the slides in presentation mode?
Yep.
Yes, perfect. Thank you. All right. So uh, briefly wanted to talk about sort of what we can look at in terms of pharmacology, right? So in this case, sort of primarily alcohol was the primary drug of choice, but um, as we all see in our clinical settings that we can see, sorry, I tend to say veterans instead of patients. So if I say veteran, please know I mean patient. Um, that we will see our clients struggling with multiple substances. But sort of real quick, when we're looking at pharmacology, we know, we all know here that we want to treat. We no longer call it dual diagnoses because so many of our folks are having multiple diagnoses, right? So it's co-occurring disorders, right? And we know that sort of treating both at the same time is going to be what's most effective for our veterans, right? But also they might not be ready yet. But we're looking at, so, we have our FDA approved medications for sort of what we would call sort of the organic mental health disorders, as well as the off label options. And then we have our FDA approved MAT for substance use disorders, as well as off level medications, right? So we're sort of, looking at all these categories all at once and sort of how they sort of intertwine and sort of all these options. And especially for our veterans who are coming for the first time and maybe are considering medications but not sure, it's really trying to figure out sort of what options do we have, but then of those options, right, sort of the menu could be very long, but how not to bombard or scare them with all those options. So, as we're talking with them, trying to figure out what their goals are, but also, when I first see sort of how our intake process is, as Eric mentioned, is that he will be able to see somebody for an hour and a half and get the psychosocial history. And then, sort of, the prescriber portion is often just half an hour. Right. So, especially for somebody who's going through trauma, when I'm first seeing them, I will just first open up and say, my part of the intake is to talk about medications. But I'll joke of, I don't get a kickback if you take a medication or not, So sometimes and I'll just give examples of, some patients, some folks I see, they're interested in medications and they're ready to try medications. Other folks just want to hear what options we have and just consider them. And other people aren't interested in medications yet, and sort of we're here to meet you and see what feels comfortable, but I don't want them to feel that I'm assuming or going to sort of force them to take a medication, with the caveat, of course, if somebody was actively suicidal or needed immediate medical care, of course we would come from more of sort of a paternalistic medication recommendation style at that time. So often, we know that sort of with WebMD and social media and people just being more transparent with their loved ones, often people will come to our appointments with ideas for treatment, right? Sometimes they're appropriate, sometimes not. But I like to ask sort of if they've thought of things, because while we're looking at treating everything at the same time, often they've been spending so much of weeks, months, years, even trying to figure out kind of this chicken or egg of, right, am I drinking because of what happened to me, or is it the other way around, or is it both? So often we'll have veterans come in sort of with being open to maybe taking a medication but wanting to focus just on one thing, right? So we'll hear things of, well, if I could get better sleep and less nightmares, then I wouldn't drink, right? So if I'm hearing that, then I'm hearing, okay, so they're interested more, they're open to medications more for PTSD at this time. Or vice versa, right? If I could back on my drinking, I wouldn't be getting numb and dissociating, right? We're so I'll try to hear, look out for any of those comments, kind of this change talk, because while I want to treat both, I want to make sure that sort of I'm validating sort of what their goals are and what they want to work on. But sort of also with that, if they're ready to sort of try medications for one of their diagnoses, making sure to them, I'll use a pie chart analogy of, if we make a pie chart of things, we know that medications are just one part of this, right? There's going to be parts of that pie for, 12 step, for time with your family, for individual therapy, group therapy, exercise, right there, and everybody's pie chart is going to be different, but we need to make sure that it's not just, one single thing that you're doing. So, for if somebody is resistant to medications for one of their diagnoses, really trying to then encourage or stress that sort of, then for those diagnoses, that therapy's their medication. Um, and because of that, want to ensure that while they might not be ready to sort of jump in and, for example, fully start doing any like prolonged exposure therapy for their trauma, we're still recognizing that that's something that we want to treat. And we want to make sure that we're not using any language that seems to say like, well, we'll work on that later. We'll pause on that later, right? Because they're coming, they want to work on things, and we don't want it to seem that um that we're going to, as providers, kind of sort of rank or sort of add value to something or negate something. um Overall, when I'm looking at, and I'll talk about specific medications in a second, but what's helpful with their use is trying to ask about their pattern of use, right? So we'll have people that say that, they don't, if they're working full time, they don't use substances during the day, but as soon as they come home from work or at night is when they start using, right? So if I'm hearing that, then I'm just thinking automatically and going through my mental list of medication options that this is somebody that might have difficulty remembering to take medications at night, especially if they're using and blacking out. Right. So if I'm looking at an antidepressant to help treat their PTSD, probably don't want to look at something that's at bedtime that maybe they're not going to be taking most nights if they're still using, if they're not ready for complete abstinence, right? And looking at something that they would just take in the morning to know that that would have better compliance and be able to reach a steady state quicker. So briefly, in looking at MAT for alcohol use disorder, especially since this was the veteran's primary drug of choice, right? We have our options of naltrexone, acamprosate, off-label for gabapentin, disulfiram, and topiramate. So for him, and kind of looking at options, um, his he came to us already on Vivitrol, but of course I would have looked at the Vivitrol as an option for him. A camprosate, of course, has a lot of benefit for him, and sort of talking about issues with motivation. Knew that the idea of him having to take something 3 times a day, especially since he was coming to us not having taken medication for years, um, knew that that was going to be a possible obstacle for compliance for him. Is also considering gabapentin because so we will use it to help with cravings for alcohol, but also has that potential as for anxiolytic benefit, especially if we're wanting to look at something um, that's sort of that might be perceived as sort of a safer alternative to something like a benzodiazepine. And while his alcohol use was heavy, we were fortunate that he wasn't experiencing any neuropathy. But there is that benefit that if we do have somebody with alcohol use issues and neuropathy, that gabapentin could be beneficial for us too. Um, if other substances are involved, um, really want to make sure that we are stressing that if you're ready to make a change, this is great. We're happy that you're ready to make a change, and that we want to focus on treating all those substances. So we will have, he was not a tobacco user, which is actually pretty rare for our patient population, but we'll still have a lot of people say, well, I'm ready to quit drinking or I'm ready to quit using cocaine, but not smoking it. I still have to have my cigarettes. I still need to be able to have that as a vice. Right. So we have some great opportunities there to provide some patient education. Say, hey, oh, actually, studies are showing if you quit smoking at the same time you quit your substance of use or your drug of choice, right, that there are longer rates of recovery, right? And also validate, that we've listened to them and talking about their use of, hey, you said that you were, that when you drink at the bar, you're always smoking as well. So it sounds kind of hard if you're trying to remove that one part, but you're still going to have this muscle memory and still want to smoke at the same time. So like that sounds really difficult to try to just remove one part of that. And it really makes sense that if we sort of remove sort of both at the same time to help, your reward center, those brain circuits kind of really rewire um, but also validate that it is difficult to quit, whether it be one substance or multiple, right? Um, he did not have any cocaine use, but something that we always ask about since alcohol and cocaine use often go hand in hand, right? Unfortunately, we don't have any FDA approved MAT options yet, but off label options for consideration, especially for somebody who has co-occurring PTSD. Um, I would be hesitant to try bupropion. While it is something that we will look at for treatment of cocaine use disorder and cravings, since bupropion can also sort of be activating, and in some people, sort of more of a jittery, anxious feeling. I would be hesitant to look at that as a first choice for somebody with PTSD if they're already having that hyperarousal, that easy startle, sort of always scanning. I would be hesitant to try that. Um, and especially too if there is comorbid alcohol use, since it lowers the seizure threshold, we would want to avoid that. Um, for stimulant use disorders, especially, we know that contingency management can be helpful. And if somebody has co-occurring, PTSD as well as alcohol and cocaine, then we try to look at with all our medications, trying to look at something that can help sort of treat multiple diagnoses at once, right? So, for example, topiramate we know can help with cravings for alcohol, can also help with cravings for cocaine, and while when it directly help with nightmares, it could, since it is sedating, could potentially help somebody with PTSD with their sleep. um of course, with opioid use disorder, if that's co-occurring, and it sort of bring it up for, especially for somebody who's also using alcohol use, it was becoming kind of with our menus of options for each thing. We will think of Vivitrol as one of sort of the top options for alcohol use. um we but then if they have co-occurring OUD and we're thinking about using buprenorphine, or buprenorphine products like Suboxone, right? We can't do both of those at the same time. But sometimes in sort of especially in like a call situation or just trying to think of options, sort of you can sometimes see people almost consider prescribing both at the same time. In those situations, right, we wouldn't look to treat the OUD, we would look at a butte product often, but then we'd want to look at other options for alcohol use disorder, like acamprosate or gabapentin, things that are not going to sort of um, try to reverse or block the effects of our MAT for OUD. Um, in looking at how we can treat the PTSD directly, right? We often look, one of our first options we look at are antidepressants, and especially the SSRIs. For him, we chose escitalopram because he had previously tried fluoxetine and found that he had sexual side effects with it. While we like fluoxetine because it has a shorter half, or sorry, excuse me, fluoxetine has a longer half life. So if we're worried about somebody having poor compliance with medications, it's a great option there. But he had some sexual side effects for it. So then, in thinking of of our options, what's going to have the most buy-in for him, and what side effects might be reasons for him to stop a medication on his own, which he had done in the past. Right? So, in looking at those options, chose escitalopram because it's less likely to have those sexual side effects from fluoxetine, and he was able to feel that fluoxetine helped his mood. But and would have kept taking it if it weren't for those side effects. Other things that we can consider are SNRIs, and especially with our veterans at the VA that might have some chronic neuropathic pain. Um, often, usually we'll look at starting for somebody who's med naive for PTSD, we'll look at an SSRI first. But sometimes, especially if there's co occurring chronic neuropathic pain, we might look at starting an SNRI first. Um, Especially duloxetine has some better benefit for neuropathic pain than venlafaxine. Um, but sort of also needing to ensure that hepatic monitoring is in place, especially for somebody who's using alcohol or because of their substance use has a history of hepatitis. Um, Lastly, and especially for somebody who's like, I'm open to taking just one medication, like just the idea of taking a single medication is a lot for me, so I'm ready to try one, right? Often we'll look at mirtazapine because it will target PTSD symptoms, depression, and can help sleep. It doesn't directly target nightmares, um, but sort of it can help with sleep and really trying to sort of maximize a number of benefits if somebody's ready for just a single medication. But also being really open, with my veterans of, here's what I'm thinking, here's the potential benefits, but I also don't want to sound like a snake oil salesman and say that's going to fix everything, right? But sort of, I get that people don't want to take more medications. So this is what I think kind of will tick most of the boxes of things that you would like to work on right now. But that we're still going to meet and kind of we might need to fine tune these doses. We might need to look at other options. But for today, let's make this change. Let's follow up and see. And especially for our patients with PTSD, treatment of sleep is huge. We know that sort of their sleep abnormalities are one of the reasons why they use in the first place. Um, so we will often use prazosin to target nightmares. Um, we will, and sort of in the way that I describe that and explaining sort of how it's sort of counteracting the effects of adrenaline is a way that then I can also validate of, right, you're waking up from this dream, your adrenaline's sky high, you're sweating, you're feeling shaky. So I can validate and sort of say, sort of teach back or say back to them what they've been telling me so that they know that I'm listening and really hearing why they're coming to treatment. Um, we have so many people that say that they're self-medicating to sleep, right, with their substances. So often, sleep medications might be the first medication they're open to trying. I would caution that sometimes trazodone can cause vivid, disturbing dreams. So for people with PTSD, it's usually not my first option that I look at. And if there is comorbid alcohol or cocaine cravings, we'll look at topiramate first to help with sleep. Or, for example, gabapentin, we have some people who aren't ready to try that TID yet, but open to trying it first for sleep. And I know for sake of time, I really want to stress that sort of the one of the key things for him is that he had untreated sleep apnea. And sort of really encouraging him to engage with the sleep clinic and us trying to find a way that he could tolerate wearing a CPAP. We have so many veterans with military sexual trauma that unfortunately happened at night, and the idea of wearing a full face mask is too triggering. Often we will need to sort of mention that first or say, hey, have you noticed it all being triggered by that mask? I've had some other people say that that can really make them feel uncomfortable. They don't necessarily bring that to the forefront. So, sort of mentioning that that can happen and letting them know too that there's other masks we can look at, other ways that we can treat that, but stressing to them that we have medications that we can try, but until we get your sleep apnea better controlled, sort of none of our medications are going to be as effective as we want them to be. And so sorry, but for sake of time, I really just wanted to give a shout out though to SAMHSA. They have this great protocol manual called Tip 42. It's over 300 pages on how we can treat substance use co-occurring with other mental health disorders. There's a whole chapter on PTSD, as well as borderline personality disorder, bipolar disorder, major depression. It's a great free resource. And I just wanted to make sure I got a chance to shout that out real quick.